Hello everyone, I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. Our topic today about secondary postpartum hemorrhage. It is a very important topic, as you know. So what are the objectives? Okay, the objective of this lecture to know the definition of secondary postpartum hemorrhage, the epidemiology, etiology, clinical presentation, diagnosis, and treatment. Okay, so what about the definition of secondary postpartum hemorrhage? It is defined as excessive vaginal bleeding in the period from 24 hours after delivery to 12 weeks postpartum. This is the most recent definition. The older definition extends in a period from 24 hours after delivery up to 6 weeks postpartum. But the most recent definition is talking about from 24 hours after delivery up to 12 weeks postpartum. Okay? So, secondary postpartum hemorrhage is an important cause of maternal morbidity and mortality. Basic resuscitation, followed by investigation and treatment of the specific cause of hemorrhage are essential. So, what about the epidemiology? The overall incidence of secondary postpartum hemorrhage in the developed world has been reported as 0.4 up to 1.4%. And of course, the incidence of secondary postpartum hemorrhage is lower than the primary postpartum hemorrhage. Personal history of secondary postpartum hemorrhage is a strong predictive factor. It has a recurrence rate of 20 to 25%. So if you have a patient with previous history of secondary postpartum hemorrhage, she is at risk of recurrence of this condition. And the recurrence rate reached 20 to 25%. Okay? Okay. 95% of women with secondary postpartum hemorrhage present within the first month after delivery. 19% within 7 days from delivery. 41% in 8 to 14 days from delivery. 23% in 15 to 21 days from delivery. And 12% in 22 up to 28 days from delivery. So you can conclude that most of the cases in the first months after delivery, 95%, and the period between 8 to 14 days, 40 constitutes 41% of cases. Okay? What about the etiology? The most important etiology is the uterine infection, endometritis, and the retained placental fragments or tissue. This is the commonest causes of secondary postpartum hemorrhage. Uterine infection or endometriosis may occur in some patients, especially those with premature rupture of membrane, prolonged labor, cesarean section delivery, especially emergency cesarean section. Okay? So the commonest two causes, uterine infection and retained placental fragments or tissue. As in this picture, this is a picture of ultrasound, abdominal ultrasound. This is the uterus. This is the cavity of the uterus, and the inside here, retained part of the placental tissue. What else as regard the etiology of secondary postpartum hemorrhage? Abnormal involution of the placental side because of inadequate closure and the sloughing of the spiral arteries at the placental attachment site. What else? as the etiology of secondary postpartum hemorrhage. Placental abnormalities like placenta accreta spectrum. You may ask me or tell me that the placenta accreta is a cause of primary postpartum hemorrhage. Yes. If still part of the placenta inside the uterus and managed conservatively with methotrexate therapy or without, this patient may develop secondary postpartum hemorrhage. Okay? And in this situation, she may need an operation like hysterectomy as a management of such a condition. What else in causes of secondary postpartum hemorrhage? Gestational trophoblastic disease, choriocarcinoma, also bleeding disorder and coagulopathy, and the use of anticoagulants, another cause of secondary postpartum hemorrhage. Congenital hemorrhagic disorder like von Willebrand disease, in which there is quantitative or qualitative deficiency of von Willebrand factor, factor 8 deficiency. Carriers of hemophilia A, factor 8 deficiency, hemophilia B, factor 9 deficiency, and factor 11 deficiency. So we have von Willebrand disease, carrier of hemophilia, factor 8 deficiency for hemophilia A, or factor 9 deficiency for hemophilia B, and factor 11 deficiency. So all these coagulopathies can cause secondary postpartum hemorrhage. Lower genital tract trauma. This missed vaginal laceration and the hematoma may present as a secondary postpartum hemorrhage. Also, infected suture line and episiotomy site may lead to wound breakdown and result in excessive vaginal bleeding. Also, vascular abnormalities like arteriovenous malformation and pseudo aneurysm in the uterine artery, as in this picture, arteriovenous malformation with transvaginal ultrasound, and here was color Doppler or mosaic pattern. This vascular abnormality are causes either pseudoaneurysm or arteriovenous malformation, another cause for secondary postpartum hemorrhage. Uterine abnormalities, as in case with fibroid, but fibroids commonly causing primary postpartum hemorrhage, but can be also a cause of secondary postpartum hemorrhage because of uterine enlargement and decreased uterine involution with fibroid. This leads to prolonged bleeding from placental bed. Another cause for secondary postpartum hemorrhage is cesarean section wound dehiscence or surgical injury. Also cervical carcinoma. These are causes, but as I said before, the commonest causes are retained placental tissue and infection like endometritis. What about the clinical presentation? The patient may complain of spotting on and off for days after delivery, with an occasional gush of fresh blood, which may be severe or horrible bleeding. About 10% of cases will present with massive hemorrhage. And of course, this may cause morbidity or mortality because quickly leads to hypovolemic shock with decreased urine output, dizziness, and the change in mental status. Additional clinical features depend on the underlying cause. For example, endometritis. The patient presented with fever and rigor with lower abdominal pain and foul-smelling glossia. Glossia is the vaginal discharge during puerperia after delivery. How to reach a diagnosis: history, examination, and investigations. History taking should focus on three primary items. What are the three items? Severity of the bleeding, which may affect the general condition, any previous interventions, potential risk factors. Assess the severity of the bleeding by asking the patient about the amount of immediate post-delivery bleeding, the pattern of bleeding since the delivery, and the current amount of bleeding. Bleeding that soaks through at least one bed per hour and or the passing of blood clots the size of an egg or larger represent excessive bleeding. So you should ask the lady how many beds soaked per hour. If at least one bed per hour, means there is a bleeding, severe bleeding. Also, presence of large blood clots size of an egg or larger represent excessive bleeding. Evaluation of this bleeding, of course, is subjective, so it is liable for error or mistake. But there is method objective for quantification of the blood loss. Involve the equation that measures the dry gram weight of an item and subtract it from the wet gram weight of an item. The result of that equation is equivalent to the millimeter of blood test. Means if there is a bed soaked with blood and another dry one, the difference in weight of both of them equal to the millimeter of blood lost. Simply like that. This is an objective quantification of blood loss. Ask about symptoms of hypovolemia and determine whether she underwent any intervention for immediate postpartum bleeding. Any medication given like oxytocin, carboprost, misoprostol, ergonovine, any blood transfusion, any surgical procedure, you should ask about all of this. Then ask about the risk factor for secondary postpartum hemorrhage related to labor and the delivery complications such as placental abruption, intrauterine fetal demise, abnormal placentation, or severe preeclampsia. Then physical examination. A complete physical examination should be done to look for signs of hypovolemia like hypotension, tachycardia, tachypnea, weak peripheral pulse, delayed capillary refill, pallor, skin mottling, and altered mental status, as well as signs of coagulopathy like bruises, petechiae, mucosal bleeding, or signs of bleeding tendency. So, general examination is very important also. Abdominal and pelvic examination include palpation of the abdomen for tenderness, which is a sign for endometritis, uterine infection. Also palpate for distension, uterine enlargement, and bladder over distension. Bimanual examination should be performed to assess uterine boginess, enlargement or tenderness. Perineal and speculum examination is important to evaluate the current status of the bleeding, the presence and extent of lacerations, hematoma, and malodorous lotia, as well as to take high vaginal swab. When you are suspecting endometritis, you are in need for such a swab for infection. What about the laboratory test? full blood count, coagulation profile, blood group and Rh factor, urea and electrolytes, C-reactive protein, blood culture. If the patient is pyrexia and you are suspecting endometritis or sepsis, please do blood culture. Human chorionic gonadotropin may be needed if you are suspecting gestational trophoblastic disease like choriocarcinoma. And also if you are suspecting retained product of conception, or even a new pregnancy if secondary postpartum hemorrhage occurs late. Imaging. What about imaging in secondary postpartum hemorrhage? Ultrasound with color and the spectral Doppler is important. Ultrasound findings are often non-specific in endometritis. The uterus may have thickened, heterogeneous endometrium, intracavitary debris, fluid, or gas, infected retained placental tissue or hematoma may be present also, like this picture, infected retained placental tissue here. Retained product of conception appear by ultrasound as a solid echogenic intracavitary mass, solid echogenic intracavitary mass, as in this picture, that extended to the endometrium. Color and the spectral Doppler showing high velocity, low resistance arterial flow in the mass differentiate placental tissue from hematoma, but is not always present in the retained tissue. Why? Because some retained placental tissue are devitalized and separated from the endometrium. So there is no blood flow, so simulating the hematoma. Okay? Also, I can diagnose by ultrasound and color Doppler uterine arteriovenous malformation with its characteristic appearance. Presence of tubular hypoechogenic structure in the myometrium, as in this picture. Bicolor Doppler ultrasound show low resistance, high velocity flow pattern with color mosaic, as in this picture. And I have a previous lecture of uterine arteriovenous malformation. Please go to my site on YouTube channel and find this lecture. It is important. Another vascular problem is the pseudoaneurysm, and I have another lecture about it recently. You can find it on YouTube channel. The pseudoaneurysm and this picture have a characteristic sonographic appearance manifesting as pulsating, anechoic or hypoechoic structure connected to the parent artery by thin vascular neck. Spectral Doppler represents turbulent arterial blood flow with to and fro pattern in uterine artery pseudoaneurysm. This picture shows aneurysm here, uterine artery pseudoaneurysm. This is in longitudinal view, and this is in transverse view, and this is with using color Doppler. You can find the two lecture of uterine pseudoaneurysm and arteriovenous malformation. I did it recently. What about treatment of secondary postpartum hemorrhage? First, assessment of secondary postpartum hemorrhage and the focus on woman hemodynamic stability. This is very important really. If she is deemed unstable, for example, she has symptoms and signs of hypovolemia and substantial ongoing bleeding, immediate transport to an emergency care facility is required, and the oxygen should be administered and the two large bore intravenous lines should be established as soon as possible for fluid replacement with crystallized solution until blood is available for transfusion. So we are in a very emergency situation. But if the patient is deemed stable, the healthcare provider should obtain thorough history, and conduct a physical examination to assess potential causes of bleeding. Also, should continue to monitor the patient's hemodynamic status because deterioration may happen at any time. In case of massive secondary postpartum hemorrhage, management includes 4 components which should be undertaken simultaneously. Like what? Communication and call for help, resuscitation, monitoring and investigation, arresting the bleeding. Arresting the bleeding either by medication, by surgical operation, and so on. So, the 4 important items include communication, resuscitation, monitoring and investigation, arresting of the bleeding. Should be done simultaneously with cases with massive secondary postpartum hemorrhage. So the treatment modalities may be medical treatment like uterotonics, antibiotics, in case of infection, tranexamic acid, clotting factor concentrates, or hormonal therapy. Surgical measures like evacuation of retained products by suction evacuation or DNC, but take care because the uterus is soft and liable for perforation. Uterine tamponade balloon, uterine compression suture like B-Lynch suture, bilateral hypogastric artery ligation, or hysterectomy in some cases. All these different surgical measures, any one of them can be done, and if one failed, I can go to another surgical operation up to hysterectomy to be life-saving. Okay? Radiological intervention, another line of treatment modalities by bilateral uterine artery embolization, and also it is very helpful in different causes of secondary postpartum hemorrhage, and one of them is uterine arteriovenous malformation and uterine aneurysm, pseudoaneurysm, as I mentioned before. So, medical treatment, surgical measures, radiological interventions. What are the examples for uterotonic? Oxytocin or centometrine, including oxytocin plus ergometrin, carboprost, which is the prostaglandin F2, misoprostol, prostaglandin E1. Antibiotic, you give broad spectrum antibiotic, ampicillin plus gentamicin plus metronidazole. If there is sensitivity to ampicillin or penicillin, we can give clindamycin. Okay? This is especially given the antibiotic in cases of endometritis. What if the patient has von Willebrand disease or other coagulopathy? You should consult hematologist. Proper management is needed with clotting factor concentrate. But I want to tell you something about von Willebrand disease, that hemorrhage usually occur 2 to 5 days postpartum. Why 2 to 5 days postpartum? Because during pregnancy, the factor is increased. After delivery, begin decreasing. So, the symptoms of the bleeding may happen 2 to 5 days after delivery. And you should know also that patients with von Willebrand disease at risk of late postpartum hemorrhage up to 4 months. So, start 2 to 5 days after delivery and may happen up to 4 months postpartum. As regards the surgical management, to know the varieties of treatment, suction evacuation or DNC for evacuation of the retained placental content, uterine tamponade, as in this picture, uterine tamponade balloon, like Bakri balloon, to control bleeding, Uterine compression suture, like in this picture, B-lunge suture, B-lunge brace suture, as you see here. Bilateral hypogastric artery ligation, as here. This is the internal iliac, the anterior division of internal iliac ligated, or even hysterectomy in some cases. In this picture, this is uterine artery ligation, bilateral uterine, on this side and the other side, and also the communication with the ovarian vessels at the cornea can be ligated also. If filled, go to internal iliac artery ligation. If filled, do hysterectomy. Another alternative for treatment and needs experienced intervention radiologist, bilateral uterine artery embolization and selective arterial embolization. And this picture show angiography, and this is before embolization. This is the hemorrhage here. This is for arteriovenous malformation. In case of arteriovenous malformation in the right uterine artery, embolization happen, and this is the post after embolization. Closure of the vessel happened and to control bleeding. This is bilateral uterine artery embolization, one of the important methods to control secondary postpartum hemorrhage. So we can summarize that different lines of treatment for secondary postpartum hemorrhage, but you should diagnose and manage at the same moment. Medical treatment using uterotonics like ergometrin, oxytocin, centrometrin, tranexamic acid, oxytocin. Also, you may need also antibiotics, broad spectrum antibiotics like clindamycin, metronidazole, and gentamicin to control infection. This is as regard the medical treatment. Surgical operation may be D&C or suction evacuation to remove the retained placental fragments. Or you may use intrauterine balloon to control hemorrhage, intrauterine tamponade. Also, you may need to do B-lunge suture, anterior iliac artery ligation. If failed, I may need hysterectomy, or the alternatives for surgery is to do uterine artery embolization as in this picture. This is the end of my lecture today. I hope it is clear enough. Thank you, everybody. This is my 3 scientific site, one for Amazon for my books published on Amazon, and another one for my YouTube channel where you can find many lectures in OB-GYN, and the third one on Blogspot, many articles in OB-GYN and picture of some of my operation. Thank you, everybody. My best wishes for all of you.